Good evening, everyone.
Good evening. Good evening.
So today is the 65th issue of our Environmental and Occupational Health DigiConnect webinar. I, on behalf of AUSD, I welcome every one of you. So we have got two learned speakers today. Dr. Vanita Arora, she is Senior Consultant, Electrophysiologist and Interventional Cardiologist at Apollo Hospital, New Delhi, and she has been an old associate of us, and we had learned a lot from her during previous sessions also. So I welcome Dr. Vanita Arora, and our second speaker is our own Dr. Rajiv Kumar Jain, Senior Vice President of AUSD. So on behalf of AUSD, sir, I welcome you all, and I request our President Dr. Jain Kumar sir to please welcome.
Good evening, friends. I welcome you all to this 65th issue of our webinar series, which we are having on every Saturday. And today we have got two speakers with us, Dr. Vanita and Dr. Rajiv. Dr. Vanita is a leading cardiologist, and Dr. Rajiv Kumar is our Vice President. Topics are interesting. So with these few words, I welcome you all to this webinar and hand over to Dr. Sandeep Sharma to proceed further.
Thank you, Dr. Jain Kumar sir. So good morning, good evening, madam, and once again, welcome to our this Association of Environmental and Occupational Health. And we are all from Indian Association of Occupational Health, which is an all India body, and we have about 3,000 members, and we had been conducting these connecting webinars with all our members across India for last 1.5 years during this COVID pandemic. And it was an enduring effort on our part, and it showed our resilience that we want to learn something, and we want to connect with everyone, every member of us, and it was the connection and the strong repository of our good senior colleagues from different fields who have helped us out every week at 6:30 p.m. and all our these learnings, they are all recorded, and they are there in our ENOC DigiConnect webinar platform also. Any of our member can go and visit this YouTube channel and refer to what is. So it is a great academic activity which we have been doing for last 1.5 year, and this was a small introduction of our association and our activities, especially during this COVID period. And madam, actually, we had been trying to mitigate this COVID for last almost now more than 1.5 years, and we have seen all the sufferings and all the problems which are being faced by the industries and the workers and the population across the globe. And still we are not under control of the pandemic. And now what we are seeing after so many infections, so many recoveries, that there are a lot of people who suffer from different post-COVID symptoms. And especially the fear which is there in their mind is the cardiac issues, because a lot of clotting issues and inflammatory issues, they are there in post-COVID patients also. And in this regard, we had heard from some of our cardiologist friend, although the cardiac issues, they are not so relevant post-COVID, and but still we have to treat the symptoms, and accordingly we have to investigate whether that particular patient is having some cardiac issue or not. But still, what we have seen that yes, there are a lot of sudden cardiac arrest, sudden deaths which had happened even when the patient was under recovery, or when the patient has recovered from the COVID, and he was feeling that he has conquered, but still he suffered. So we would like to understand what this sudden cardiac arrest, how this happens, whether what is the etiology, pathology, and how to tackle with this, because arrhythmia issues, other things, they are also there. And it will be our pleasure to learn and hear from you, ma'am. And to all our audience, all our members across India, to introduce Dr. Vanita Arora. She is Senior Consultant Cardiac Electrophysiologist and Intervention Cardiologist at Apollo Hospital in New Delhi. And as the first female electrophysiologist of India, Dr. Vanita Arora is a pioneer female cardiac physiologist in the country. And she has earned the awards like Rising Star in Cardiology, Women Doctor Entrepreneur of the Year 2080 with Chikitsa Ratan, along with several other outstanding achievements. Dr. Arora has been a distinguished faculty member in several national and reputed international meetings, such as Heart Rhythm Society and Asia Pacific Heart Rhythm Society. And she is elected Secretary of Indian Heart Rhythm Society. Dr. Arora is a leader in providing her patients with world-class medical care, and is now propagating new technological innovation in the field of electrophysiology. And she has been the first in the Asia Pacific to do the live case of a leadless pacemaker at TCT India conference in 2016. And she works tirelessly towards her profession, giving state-of-art patient care with excellence, with immense interest in classical music also. She is also a keen explorer and a vivid reader. So with this, madam, it is our great opportunity to hear from you regarding this cardiac arrest and post-COVID patients. And the floor is yours, ma'am. You can start your deliberations. We are eager to hear and learn from you.
Thank you so much, Dr. Sharma, for the kind introduction. Thank you, Dr. Gajendra, for this kind welcome. It's a pleasure to join you all on the topic, which is very serious, of sudden cardiac arrest. Whether sudden cardiac arrest occurs with or without COVID, it is a terrible thing, because before COVID also, we had so many lives that were lost because of sudden cardiac arrest, and people not understanding the difference between an MI and a cardiac arrest used to label that as heart attack, or it was a misnomer which was being used. Now that we've seen that there is clot formation during COVID, which is causing either an MI or a pulmonary embolism. But apart from that, patients recover very nicely and then go back home, and after a couple of weeks, they just collapse suddenly. That's how people have started realizing the difference between sudden cardiac arrest and MI. I'm talking of lay people. I'm not talking of physicians, but a lot of questions are coming to us now, that what do we do and how do we take care of it. I just want to bring to your notice that there were two young doctors who were lost in Mumbai just 10 days back. One of them was a gynecologist, the other one was an intervention radiologist. Both of them had COVID. they recovered very well, and one of them collapsed after coming back from the gym, and second, the other doctor, he collapsed at the workplace. And these are kind of news that we read, and we got to focus on the things what is happening. So you all must be having examples of such incidences which have occurred during our clinical practice of COVID, because all of us, by and large, whichever specialty we belong to, we have become COVID experts. With the type of a pandemic that has happened, and especially the second wave which happened in Delhi, it has converted us all, because there were no doctors or physicians available. So patients were trying to get in touch with all the doctors, and we had to read just to guide our patients, because you cannot leave the patient in a lurch. So even as a cardiologist, I learned about COVID. Even, I mean, whichever specialty you all are in, you must have learned about COVID. So I would say we have all become COVID experts. And apart from that, we will be discussing about what sudden cardiac arrest has with us, and what can we do to avoid it, especially in patients of COVID. What are the risk factors and how do we avoid it? So, sudden cardiac arrest, you all know this picture. I have put it because we realize as a patient who has dropped, uh, there is no medical help available and something is going on. So the early CPR is the way to save these patients. But in the background, what is going on is this kind of an arrhythmia. Now, this is a halter of a patient, and of a patient who was on a halter while being investigated for arrhythmia when he died, and he's left us this recording. See, it's just a difference of hardly 9 minutes. And look at this, patient was in sinus rhythm. A couple of PVCs triggered an arrhythmia. Now, this arrhythmia became faster and then degenerated into a VF. Ultimately, it went into a asystole. So now the substrate for this arrhythmia has to be LV dysfunction. This kind of arrhythmia cannot happen in a normal heart function until unless you have an underlying disease like a long QT syndrome or a Brugada syndrome. But maximally, this arrhythmia requires a substrate of coronary artery disease. And when we say sudden cardiac arrest, we are talking of an abrupt cessation of normal circulation of the blood, leading on to the failure of the heart to contract effectively. And the most important thing is that cerebral perfusion is hampered, so patient is lying unconscious without any breathing or pulse. And in case there people are survivors of sudden cardiac arrest or aborted sudden cardiac arrest, the recurrence rate in these patients is up to 20% within the next year if not taken care of the reason why sudden cardiac arrest occurred. And sudden cardiac arrest is it has a huge impact. We don't have any data from India. Please understand, in India we are lacking with our data of sudden cardiac arrest. There are very few, there are 3 studies in fact which have come out from India. One is from the south, one is from All India Institute of Medical Sciences, and there is one other small study, but very small number of patients talking about sudden cardiac arrest, which is in United States of America, it is huge. 60% of deaths are arrhythmic deaths, and they form about 20% of all total deaths. As compared to the cancer deaths, they are little less, but they have a huge impact. And in our country also, it has a huge impact, but somehow we do not have a data available. And the estimate survivor of out of hospital sudden cardiac arrest is hardly 5% in United States of America. And what do you think is going to be an out of hospital sudden cardiac arrest survival? The examples that I gave you today, I mean, one of the doctor had a sudden cardiac arrest in the hospital. So there were medical professionals near to him. Still, he cannot make it. The attempt should be made to for patients to survive, but whether we are able to successfully have that attempt for the survival of the patient, it really depends on so many other factors. The most important rhythm that you find in a patient of sudden cardiac arrest is actually ventricular fibrillation, followed by asystole. Once you are able to put a patient who's had sudden cardiac arrest on a monitor, these are the rhythms that you will see. And the most important factor for sudden cardiac arrest is actually coronary artery disease in India. It is 80% of the patients will have coronary artery disease. And this stands true for COVID patients also. I'll just come to that slide too. Uh, sometimes we think it is not the sudden cardiac arrest does not cause is not caused in the young patients. Well, it is not true. Patients with hereditary genetic malformations like long QT syndrome, Brugada syndrome, ARVD, well, all of them are the genetic defects and they strike the young population. Now, apart from that, you would be aware that our young population has started going to the gyms very regularly nowadays. And when they go to the gym, they want to have a good body. So, I have come across at least 15 patients, 15 young patients who have come to me with palpitations and ventricular tachycardias. When I got the cardiac MRI done, there is a scar there, and the only history I can correlate is with the intake of supplements. So the supplements which are given in the gym, they are given in form of some milk protein shake, some injections, something to inhale, just to not get tired after the exercise. They are actually not good. And I have seen survivors of sudden cardiac arrest and patients having ventricular tachycardias because of that. I have done ablations in these patients, have given them strict warning not to take these supplements ever in future again. But apart from that, there is only this much I can do. Rest, all of us have to join hands to probably check this also. In the male and female ratio, well, males are more affected with sudden cardiac arrest. Even with COVID, the males population has been affected more. Uh, just a word about the athletes, sudden cardiac arrest in athletes. Well, 1 in 300 young athletes have a heart condition and can cause sudden cardiac arrest. So we have seen patients having sudden cardiac arrest on the field. Some of them we have been able to revive, like a very recent episode of Christian Eriksen, the footballer who collapsed on the field. And well, we have lost a few. Mr. Yashpal Sharma, our hero from cricket. I mean, I know he didn't die on the field, but he died of a sudden cardiac arrest. And our own very favorite past president of India, uh, Abdul Kalamji, he also died of sudden cardiac arrest while delivering a lecture. So it is not an unknown field. We have been facing this, and uh, we have to take care of these things one step at a time. And even in case for the athletes, it has been recommended that they should have a thorough examination, however low the incidence of sudden cardiac arrest may be. But we know that these athletes, they have an athlete heart, which is the muscle becomes hypertrophied. It may be an eccentric hypertrophy, or it may be asymmetrical hypertrophy, and that becomes a source of generation of arrhythmias. To save patients from sudden cardiac arrest, we require AEDs in India. Automatic external defibrillators are the need of time at the moment in India. We should have any place. My slogan is any place which has a fire extinguisher should have an AED along with it. It is a life-saving device. We should not shy away from it, and we should have it, whether it is the police stations, hospitals, railway stations, bus stations, in our society, wherever there is a fire extinguisher, the AED should be placed there, because AEDs save life, and it is very simple to use AED as the instructions are given in the box itself. It will run you through the instructions how to use an AED. how to put the patches, how to connect it with the AED, and the AED will analyze the rhythm. In case required be, it will tell you to do a CPR. In case not required be, it will deliver a shock by announcing that it is going to give a shock first. So it is a life-saving device and it should be available. Now, in the COVID, sudden cardiac arrest incidence has increased. The main cause is because of myocarditis, the virus affecting the cardiac muscle per se. The stress that the patient passes through during the COVID time, the stress cardiomyopathy has occurred, uh, which can cause arrhythmias. Of course, we have already discussed about the myocardial infarction, the clot formation that happens in the arteries of the heart, and it causes MI, and it also leads on to sudden cardiac arrest because of ischemia. And then, because of myocarditis or stress cardiomyopathy, the arrhythmias generate because of the substrate, which is very volatile at the moment, and the drugs which have been used in treatment of COVID. First, the prevention like HCQ, which causes long QT, and then the treatment of COVID like azithromycin or erythromycin, which have been used, and the drugs which can prolong the QT interval and cause arrhythmias. So these are the reasons why a patient can have sudden cardiac arrest. And you have to also know that once the patient is discharged from the hospital, then once the patient is stable and discharged from the hospital, then patient can have sudden cardiac arrest. So it is important to monitor the rhythm of the patient when the patient is admitted, to know in case patient is having bradyarrhythmias, in case patient is having tachyarrhythmias, or patient is having VPCs, frequent VPCs. Then the patient should be evaluated further to get an echo done, especially echocardiography, to see for any LV dysfunction, and keep a very close watch on these patients for any occurrence of arrhythmias. Now, here we have to also remember that severity of illness of COVID is an independent marker of cardiac arrest and arrhythmias. So more sick the patients, however they recover from the COVID, you have to keep a watch on them. And unfortunately, except for echo or the cytochrome storm causing the parameters which are raised during the cytochrome storm, you have to follow them carefully and get an echo done along with that. Monitor the arrhythmias, and then maybe you will be able to save the patients from sudden cardiac arrest. That's all I have had to discuss with you all. If there are any questions, I'll be happy to answer. This is just a slide showing that we should be saving a life, and we should all learn how to do a correct CPR and have this what should I say, the all the population should learn how to do a CPR, and that is the way we can save lives.
Thank you, Dr. Vanita, madam. This was a learning for us that increased incidence of the sudden cardiac arrest, especially in post-COVID patients. It accompanies the cardiac problems which people might be having from earlier, or the lifestyles which they had been leading earlier, like they had been regular visitors to the gym, or they had been young athletes, or they are having some cardiac problems. And during this post-COVID treatment also, and during COVID treatment also, the myocarditis, stress cardiomyopathy, myocardial infarction, or the arrhythmias, they can be one of the causative factors for the sudden cardiac arrest. And now our panelists might be having some questions for the learned speaker. First, Dr. Gajen Kumar, sir.
First of all, I compliment Dr. Vanita for such a wonderful presentation, short and crisp and absolutely to the point. Wonderful presentation indeed. Now, ma'am, I have two questions. My first question is there any protocol or you recommend that any patient who is being admitted to the hospital for COVID before discharge must be subjected to ECG? This is my first question. Because anybody who is admitted to the hospital for COVID, it is for sure that he is a serious patient. Otherwise, normally 80% of the patient are, taken care at the home isolation itself. This is number one. And my second question is, in railways, in fact, we have gone a long way for providing these equipments for defibrillation, ADCs, at railway stations and all in our health units and our hospitals. We have got 125 hospitals across the country. I work in the railway as chief consultant in Central Hospital, Connaught Place, Railway Hospital. We have got 125 hospitals and 586 health units across the country. And we provided this equipment to all the places. Beside this, all big railway stations as well. But over the year, what we have noticed, in spite of the fact there are instructions, the instructions are there in the language or the phonetic is Western, not the Indian English or Indian local language. This is one hurdle. Another hurdle is, in spite of the fact we have trained the people to how to use it, after some time, whenever there is a need or we go for a mock trial, nobody is able to open it or to use it. And with the result, with the passage of time, the battery drains out and the equipment is put into some store or somewhere. So what is your comment on such a scenario in our country as far as this equipment is concerned? These are my two questions.
So coming to your first question about which patients should be screened for any sudden cardiac arrest. Sir, the patients who are reaching the hospital, you are right about it, that they are the sicker patient, the sicker group of COVID patients who have reached the hospital with the low saturation. Now, patients who have reached there, they will be, they are in the ICU. The monitoring of the rhythm has to be done there. There are very common arrhythmias which are seen with COVID in form of bradyarrhythmias. I have seen six sinus syndrome. I've seen AV conduction disease. I've seen very frequent PVCs, the ventricular ectopics, or rounds of non-sustained VT, even atrial fibrillation. All these arrhythmias have been seen with COVID. So these patients, whoever present with these arrhythmias, they should undergo a cardiac MRI. And more than often, we have seen edema as a part of myocarditis. The intensity may be different, but edema has been documented in cardiac MRI. And starting steroids in these patients, they help. So steroids you are anyway giving in patients who have a fall in the saturation, or whom you think are going into cytokine storm. To prevent them, you are anyway giving steroids. So these patients are also helped with that. Secondly, patients I know of a patient who stayed in the hospital for almost 40 days with COVID. He had a baseline trifascicular block, but now presented with complete heart block, was on a temporary pacemaker for almost 2 weeks. The pacemaker was removed because the rhythm recovered, and now he has a trifascicular block. So they are asking me whether we should give a pacemaker or not. So arrhythmias are diagnosed. Actually, we have been concentrating so much on the respiratory side effects of COVID that we have actually forgotten about the cardiac, and it is only that late we have come to know that there are cardiac side effects also in form of, and that also in form of sudden cardiac arrest. When you worked very nicely for all the other parameters, you lose the patient because of sudden cardiac arrest.
Right.
So we have to keep a close eye on these patients to monitor them for arrhythmias. So the answer to your second question, sir, about the AEDs, it is commendable that you have done such a good work. In fact, I have been involved in the launch of AEDs in a couple of metro stations myself. And you have done a commendable work of providing the AEDs on all railway stations and all buildings of railway offices which are there. I agree to you, sir, because we don't have a mental setup and aptitude towards opening that box, and we are so scared. We treat it like a bomb, कि इसको खोलें कि नहीं खोलें, कि क्या करें, किसी के आने की मदद की वेट करें कि कोई आ जाए और खोल के हमें बता दे क्या करना है. So that hindrance is there. But I think, that like you have taken the first step of providing the AEDs in the railway stations, that becomes an example for rest of them to also follow, for the public to know that this is something which will save life. So I think repeated reminders, and we have to, at least our staff training, repeated staff training would put these things in action. It is going to be a slow process, sir. It is not going to be a faster process. It is going to be a slow process, but you have taken the first step. I should compliment you for that.
Thank you. Thank you.
Thanks. Sir, if you don't mind, please, I have to leave. I have to go to another seminar, please. And it was a very, very nice interacting with you. May I take leave, sir, please?
Sure.
And
Sure,
yes,
ma'am.
absolutely.
Thank you.
We'll
Thank you.
find out some new opportunity of interacting with you.
Sure.
And
It
there
will be
are
my
so many,
pleasure.
there are so many questions, but still we would like to address them offline.
Sure. Thank
Yeah.
you.
Thank you,
so
Dr.
much.
Vanita. So this was Dr. Vanita about the sudden cardiac arrest, and it was a great pleasure to learn from her regarding this particular aspect, because this is very important for us to monitor all these cardiac post COVID cases, especially with comorbid condition and with the cardiac issues, and especially we have to monitor the arrhythmias and the rhythm of the patient, and accordingly we should get them investigated with the echocardiography or cardiac MRI as she is indicated in certain patients. So with this, we come to an end of the first session. Now our second guest speaker is Dr. Rajiv Kumar Jain, our Senior Vice President, and Dr. Rajiv Kumar Jain, sir, we had been hearing him for so many weeks, for so many months regarding the COVID-19 Epid updates, and we all know that still the COVID epidemic, COVID pandemic is still very much there, and new dimensions of COVID pandemic will be discussed and deliberated by Dr. Rajiv Kumar Jain. Dr. Rajiv Kumar Jain has got a 40 years of experience in health and hospital administration. He has been fellow of Indian Public Health Association and fellow award. He has been given fellow award of Association of Environment and Occupational Delhi, and he has published more than 145 scientific papers in national and international conferences and journals and books, and fellowship scholarship by WHO, National Institute of Health, USA, Canadian Society for International Health, International Clinical Epidemiology Network, and International Society for Priorities in Healthcare. So Dr. Rajiv Kumar Jain is also Senior Consultant Health in Indian Railways, New Delhi, and he is a pediatrician. So Dr. Rajiv Kumar Jain, we would like to learn from you about the latest updates about the COVID nationally and internationally. What is the situation right now, so that accordingly appropriate steps can be taken by respective organizations in which we are working. Yes, sir.
Good evening, friends. Here we are again on a Saturday evening. And after we have learned a lot about sudden cardiac death in COVID-19 patients, we need to update our knowledge about the current epidemiological situation of COVID-19. Why we want to learn the current epidemiological situation? Because unless we know what is the trend and what is the way forward, way ahead, we will not be prepared better than we were yesterday. So today has to be better, and to ensure that tomorrow is better than today or yesterday. And for that, we need to have the data, and we need to know the trends and the inferences from those trends, and how we need to behave, how we need to prepare ourselves better. So if you look at the slide containing the current COVID-19 situation for the past week, for the whole week, this is the trend. This is the trend where you see colors. But are these colors really bright colors? Unfortunately, they are not. Because what we see in the figure, in the picture that you are seeing on the slide on your screen, is a definite third wave going up globally. And also a fourth wave of deaths globally. The global number of new cases has been increasing for the last 2 months, with over 4.4 million reported in the past week. This increasing trend is largely attributed to increase in the Western Pacific region and the region of the Americas, which reported 14% and 8% increases respectively as compared to the previous week. The other 4 regions reported similar or a decrease in new weekly cases as compared to the previous week. The cumulative number of cases reported globally is now over 206 million, and the cumulative number of deaths is almost 4.4 million. All regions except the Western Pacific and the Eastern Mediterranean regions reported similar or a decrease in the number of deaths this week as compared to the previous week, while the African region reported the largest decline in cases and deaths, with 23% and 18% decrease in incidence respectively. Data from the weekend is incomplete, which may overestimate differences as compared to the previous week. So what we are seeing here is a trend, and trend is towards increase in the last 2 months. Next slide, please. This is in terms of new cases in the last 7 days and changes in new cases in the last 7 days. So what we see, America's 8% increase and Western Pacific 14% increase. In terms of deaths, Western Pacific 23% increase, Eastern Mediterranean 15% increase, and America's 1% increase. Other regions, Africa region deaths decreased by 18%, and Africa region cases decreased by 23%. Let's see the trends. Next slide, please. This is the coronavirus dashboard of the World Health Organization taken half an hour back. And what do we see? We see that in the last 7 days, out of 44 lakh cases reported globally, 16 lakh cases were reported by the Americas region, 11 lakh 45,000 cases by European region, 6 lakh 12,000 by Southeast Asia region, Eastern Mediterranean region, 4 lakh 68,000 cases, Western Pacific, 4 lakh 90,000 cases, and African region, 1 lakh 67,000 cases. So we can say the pandemic is still on. Let's see further in terms of countries. This is the ranking of the countries in terms of cases newly reported in the last 7 days. And what do we find? The top rank goes to United States, 9,85,000 cases out of 44,86,000 cases. Remember, USA once again is reeling with Delta variant all across USA today. And look at Iran, Islamic Republic of Iran, 2,67,000 cases, second rank in the world. And India is again at the third rank in the world, 2,41,000 cases. Brazil, 2,12,000 cases. United Kingdom, 2,12,000 cases. Russian Federation, 1,48,000 cases. Malaysia, 1,47,000 cases. Thailand, 1,46,000 cases. France, 1,41,000 cases. And once again, Japan, 1,39,000 cases in last 7 days. So new countries and the rank of certain countries going up. And that is what the dynamic situation of COVID-19 pandemic is. Let's see the situation in terms of deaths. Next slide, please. This is the situation in terms of deaths. And what do we see? Highest deaths were reported from Indonesia, 7,537. United States, 6,088 deaths in 1 week. Brazil, 5,914. Russian Federation, 5,621. Mexico, 4,266. Iran, Islamic Republic of Iran, 4,040. India, 3,335. South Africa, 2,447. Once again, you find the deaths are spread all across the world, across the continents. Next slide, please. Now we come down to Southeast Asia region. And what do we see? Cases in Southeast Asia region continue to decline this week. The region reported just over 7,31,000 new cases and 19,000 new deaths, decrease of 9% and 6% respectively as compared to the previous week. Following a spike in the regional mortality rate 2 weeks ago, the number of new deaths has been declining following large decreases reported in Maldives and Myanmar. While most of the countries reported decreases or similar number of cases this week, Sri Lanka, Thailand, and Timor-Leste reported increases in case incidence. Remember, these are new countries where cases are increasing. Sri Lanka, Thailand, and Timor-Leste. Similarly, not all countries follow the regional declining trend in deaths, as large increases were reported in a number of countries, including Sri Lanka, Thailand, and Timor-Leste this week. An increase of 63%, 11%, and 200%. 200% increase in Timor-Leste. The highest numbers of new cases were reported from India, 7% decrease, Indonesia 188,000, 17% decrease, and Thailand 150,000 cases, 7% increase. The highest number of new deaths were reported from Indonesia, 10,492, 8% decrease, India 3,363, 4% decrease, and Bangladesh 1,523 new deaths, which is 12% decrease. So you can see the trend, how dynamic the situation is around India. Now we reach India now and see what is happening in India. Next slide, please. Let us go further. We will come back to this slide later. Next slide. Next slide. Next slide. Next slide. Yes. 34,288 new cases, 376 deaths, and 17.2 lakh tests yesterday. 7-day average test positivity rate 2.01%, 3.55 lakh active cases, and shrinking by 1%. Total 3.24 crore cases, 4,33,998 deaths, for 57.22 crore vaccination doses given on 19th of August. Next slide, please. This is the current situation of states in India in terms of confirmed cases, in terms of deaths, in terms of tests per million per day, 7-day average test positivity rate, 7-day average daily growth, and vaccination persons with at least 1 dose in percentage. In terms of confirmed cases, out of 34,000 cases reported yesterday, Kerala contributed more than 50%, 20,224. Maharashtra is number 2 rank, 4,003. Tamil Nadu, 3rd rank, 1,668. Karnataka, 4th rank, 1,453. Andhra Pradesh, 1,435. Odisha, 6th rank, 966. And West Bengal, 7th rank, 758 cases. So what do you find? The South India, Western India, Eastern India, still reporting good number of cases. If you look at the deaths, Maharashtra still continues to be at the top. Out of 376 deaths yesterday, 105 were reported from Maharashtra. Kerala reported 99 deaths. Odisha reported 69 deaths. Tamil Nadu reported 24 deaths. Karnataka 17 deaths. Assam 13 deaths. And West Bengal 9 deaths. If you look at the tests per million per day, Indian average is 1264.3. Rajasthan only 368. West Bengal only 482. Chhattisgarh only 793. And Madhya Pradesh only 835. Gujarat only 857. So test per million per day is low, very low in these states. If you look at the 7-day average test positivity rate, Indian average is 2.0%, but in Kerala, it is 15.3%. In Manipur, 11.8%, Sikkim, 11.3%, Meghalaya, 11.1%, Mizoram, 7.6%. So these states are still showing very, very high test positivity rate in terms of 7-day average. If you look at the 7-day average daily growth in terms of percentage, Indian average is 0.1%. But in Mizoram, it is 1.02%, Kerala 0.52%, Meghalaya 0.43%, Manipur 0.39%, Sikkim 0.36%, Arunachal 0.25%, and Nagaland 0.22%. And the entire Northeast and Kerala is still showing very high daily growth rate in terms of 7-day average. Now, what do we see in terms of vaccinated persons with at least 1 dose in terms of percentage? Indian average is 32.87%, but in Bihar, it is 21.89%. Uttar Pradesh is 23.08%, Jharkhand 24%, West Bengal 26.48%. These states are showing distinctly lower percentage of vaccinated person with at least 1 dose. Remember, this is only 1 dose, not complete vaccination. And our Delta variant protection is after 2 doses. Let's go back to the previous slides. Yes, previous, yes, yes. This is the slide where we need to understand the luck and vaccination. At long last, we finally have an estimate of vaccine breakthrough cases 3 months after the phenomenon itself was evident from tiny social samples in the ferocity of the second wave of COVID that caught India napping this year. That we haven't any aggregate data at all is a relief. The country has recorded some 87,000 COVID positive test results among the fully immunized. 87,000 COVID positive test results among the fully immunized. If we have vaccinated 13% of our adults fully, as stated by the center, then that count represents less than 0.1% of the immunized population. This suggests a very low likelihood of a breakthrough despite the defiant Delta strain and its lineages on the loose. How accurate that estimate is remains unclear. By the same data set, 46% of breakthroughs were in Kerala, a state that's known for its diligence in testing and data gathering. Could other states have undercounted such cases? Lethargic genome tracking and dodgy data feeds in India have worsened our pandemic uncertainty, and it's vital that we eliminate our risk with more reliable inputs. Yet, even if the actual count is a few multiples higher than what has been cited, it's clear that vaccines are fending off COVID rather well. So that balanced observation, I feel one needs to understand we should be on our guard. Even if you are fully immunized, you still have likelihood of test positivity. Next slide, please. This is the distribution of alpha, beta, gamma, and delta variants of concern across the world. Alpha is in 190 countries, beta is in 138 countries, gamma is in 82 countries, and delta has now reached 148 countries. How this violet colored bottom right is expanding. And also India continues to have all the 4 variants of concern. Next slide, please. In October 2020, WHO shared the results of the Solidarity Therapeutics trial, which tested 4 treatments for COVID-19, involving almost 13,000 patients in 500 hospitals in 30 countries. The next phase of the trial, that is Solidarity Plus, will test 3 drugs. What are those drugs? First is artesunate, a treatment for severe malaria. Second is imatinib, which is a drug for certain cancers. And third is infliximab, a treatment for immune system disorders such as Crohn's disease. These 3 drugs will be tested now in the Solidarity Plus trial. The trial involves thousands of researchers at more than 600 hospitals in 52 countries, including India. Next slide, please. This is what is striking, and India must prepare for this situation what US is facing. US deaths up again, but in low vaccinated regions. The United States reported over 1,000 COVID-19 deaths, according to Reuters telling. This is the first time that the country has seen daily fatalities touch 4 digits since early April. A look at how the current rise in death is centered only to some regions with low vaccination rates. After a hiatus, deaths are rising again. Like many other countries, the Delta variant has presented a major challenge for the United States as well. After dropping nearly steadily throughout 2021, COVID-related deaths have spiked in the US over the past month, and 1,017 people lost their lives to the viral disease on Tuesday, according to a tally by the Reuters, the highest in a day since early April. The last time the US recorded over 1,000 deaths on a regular basis was in March 2021. And vaccine impact is 0.01% breakthrough infections among vaccinated that resulted in hospitalization or death. Fatalities and low vaccination, there is a correlation. As the Delta variant continues to ravage parts of the country, deaths have started to rise, but have not done so uniformly across the US. Fatalities have spiked only in some select areas, particularly those with low vaccination rates. The first map shows counties in the US that have seen a high volume of daily COVID-19 deaths in the past week. The situation is particularly dire in the south and southeast of the country, along with pockets in the northwest. Of the 10 states that have seen the most deaths in the past week, 7, Louisiana, Texas, Mississippi, Georgia, Arkansas, Alabama, and Tennessee, are located in the south and southeast. Just these 7 states account for over 50% of deaths in the past week, CDC data shows. The second map shows coverage of population by COVID-19 vaccination. The southern states of Alabama, 35.7% of population fully vaccinated, and Mississippi, 36.1%, have lowest coverage of population by vaccines in the country, followed by northwestern states of Wyoming, 37.6%, and Idaho, 38.1%. Louisiana, 38.7%, fully vaccinated, is the 5th lowest in the country. The county-wise data shows that some of the lowest vaccination regions in the US in the countries, south, southeast, and northwest, are the same that are currently experiencing high volume of deaths. So what do we learn for India? We must pace the vaccination rates very high in those states where vaccination is low at the moment, as I was saying earlier. We must do targeted pacing up of vaccination in low vaccination states if we have to protect the population of those states, namely Uttar Pradesh, Bihar, and Rajasthan. Next slide, please. Next slide. Next slide. Next. Yes. This is, now we see that Tamil Nadu, Bihar, and Uttar Pradesh are lagging in jabs for 45 plus age group. As India is fighting against time to prevent a potentially devastating third wave of COVID-19, vaccination of vulnerable groups will be key to prevent hospitalization and deaths. In a recent interview, Soumya Swaminathan, chief scientist at the World Health Organization, said India should prioritize vaccination the 45 plus population since severity of disease and deaths are high in that age group. India's record on this front has been mixed. For every 100 people above 45 years of age, India has administered 90 doses. The COVID portal does not provide the breakup of the first and second doses for specific age groups, suggesting significant coverage. But the overall figure hides significant state-level variations. Among the states that have given the least number of doses per 100 people in this age group, Tamil Nadu, 53, Uttar Pradesh, 63, and Bihar, 64, top the list. In the subset of those above 60 years of age, Tamil Nadu and Uttar Pradesh have performed even worse, having administered only 49 and 62 doses per 100 population above 60, respectively. Overall, vaccination coverage in these states also remains poor. Apart from administrative weaknesses, vaccine hesitancy could also be a reason for low coverage among the elderly. 28% of people above 60 years of age in Tamil Nadu were hesitant to take vaccines, according to a study by the State Directorate of Public Health in July. Earlier this week, India administered 8.87 million doses on 16 August, its highest ever for a single day. However, such numbers should not breed a false sense of complacency, since many people at high risk of severe COVID are still unvaccinated. Next slide, please. This is what you are seeing, which are the top 7 states with doses given per 100 population. They are Himachal, Jammu Kashmir, Kerala, Uttarakhand, Rajasthan, Gujarat, and Andhra Pradesh. And which are the bottom 7? They are Assam, West Bengal, Punjab, Jharkhand, Bihar, Uttar Pradesh, and Tamil Nadu. We must focus, and this difference between vaccination of 45 to 59 years age group shown in gray line and 60 plus shown in red line also must be understood correctly. And we must target first covering 60 plus population 100%, then equally important are 45 to 59 years age group, especially with comorbid conditions. Next slide, please. The Philippines has ramped up vaccination as it battles another surge in cases. Globally, Bangladesh seated its top spot among the 10 most populous countries in the weekly increase in vaccination coverage to the Philippines. The Philippines accelerated to 13% growth this week, even as its doses per 100 population rose to 25.8 this week from about 22.8 last week. The country saw a severe second wave earlier this year around the same time as India and is now bracing for a third wave. So far, its vaccination drive has been primarily riding on China's Sinovac. It recently gave emergency approval to the Hayatovax, which is similar to China's Sinopharm and manufactured in the United Arab Emirates. Meanwhile, India has increased its weekly growth in vaccines to 7.3% after maintaining a 6.1% growth in covering each in the last 2 weeks. Its pace is still lower than Russia, Indonesia, and Brazil, with each of them recording a growth of over 8%. The US, which has seen a spike in COVID cases, increased its coverage by 1.5 percentage points, the highest since the first week of July. Next slide, please. 323 districts reported single digit or zero cases in the past week. There has been a gradual decline. Weekly COVID-19 cases in India dropped to an average of 264,756 cases in August from around 280,000 in July, declining by 8.4% last week and by 6.6% this week. All states and union territories reported a decline in weekly cases except for Chhattisgarh, Jharkhand, and Haryana. Even in these states, the increase has been less than 10 cases. The northeastern states, which have been registering a spike in cases since the last 10 weeks, have each reported a decline of at least 30% in cases this week. However, there are hotspots at the district level. Sheep in Mizoram saw 105 cases this week after consistently reporting 31 cases in each of the last 2 weeks. The spread has shifted up north, with 2 districts in Jammu Kashmir and 1 in Ladakh reporting a spike this week. Cases in Riyasi and Anantnag increased from 7 and 14 last week to 92 and 36 respectively, while Leh reported 53 cases this week, up from 17 in the previous week. And if you look at the cases, Kozhikode, Malappuram, Ernakulam, Palaghat, and Thrissur, all in Kerala, are reporting more than 10,000 cases in the 7 days. Next slide, please. This is in terms of deaths, sub 1,000 relieved. Kerala is only major state to report a significant rise in deaths. Deaths in India due to COVID-19 were down by 5.6% in the past week, a steeper decline than in previous week, 1.31%. 10 states and union territories have reported an increase in deaths this week, but all except Kerala from a lower base. Kerala has once again reported an increase of 20.55% in deaths this week after reporting a decline of 10.24% last week. Overall, none of the states have reported 1,000 deaths this week, and Maharashtra saw a sharp decline as deaths reported in the state dropped by 24.58% in the past week from 1,265 to 954. There are 2 districts, both from Odisha, which are still witnessing an increase in mortality on a higher base. Even though deaths in Odisha increased marginally in the last week, Khordha and Cuttack saw a jump of 81.48% and 73.33% in deaths to 147 and 78 respectively. Next slide, please. Next slide. Next slide. For pandemic hit Kerala, it's a make or break Onam. And today is Onam in Kerala. I wish all residents of Kerala are very happy and people of Kerala across the country are very happy and prosperous Onam. The 10-day long Onam festival in Kerala will conclude in Thiruvananthapuram on August 21, that is today. Onam is the biggest festival in the state that spans religious boundaries and attracts a lot of the region's migrant workers back home. In many ways, Onam also marks the beginning of the festive season across India. It continues till the Christmas and New Year season. Festive demand has always been important for the economy, but it will be very crucial for pandemic-affected markets this year. This year's Onam festivities could be make or break moment for the southern states, which after being hailed as a model in the fight against the pandemic, is dealing with what seems to be an uncontrollable surge in COVID-19 cases. It was around Onam last year that COVID-19 cases began rising in Kerala, putting an end to the state's claims of successfully containing the pandemic. If there is a similar spike in case this year too, the situation, at least in terms of the medical infrastructure's ability to cope, may spiral out of control. That's a warning. Next slide, please. Onam was when COVID-19 infections started rising in Kerala last year. And you look at the graph, normalized values of daily new cases in Kerala and rest of India. You see the difference. Rest of India blue, Kerala red. Although India imposed a 68-day long nationwide lockdown in March 25, 2020 to prevent the spread of COVID-19 virus, the pandemic's trajectory was very different in Kerala and rest of India in the initial phase. Cases started rising steadily in the rest of India as restrictions were eased. However, Kerala managed to buck the spread, earning much applause for its handling of the pandemic. The situation in Kerala changed with Onam, which was on August 30, 2020. A comparison of normalized values and 7-day average of daily new infections on a scale of 0 to 1, 0 being the minimum and 1 maximum for Kerala and rest of India shows this clearly with a sudden spike in Kerala's trajectory around the last week of August 2020. The first wave of COVID-19, once it started in Kerala, took longer to subside, unlike the rest of the country. That the state has 2 rounds of polls, local body elections in December, and then assembly elections in April did not help. Next slide, please. A festive boost to mobility may have played a role in the 2020 surge, and it appears to be happening again. Mobility levels in Kerala and 7-day average of daily new cases are shown in the graph. Kerala weekly average mobility is in blue and 7-day average of new cases is in red. Given the importance of festivals for businesses, governments are always under pressure to relax restrictions. Kerala is no exception to this. Last year, the state government relaxed restrictions before Onam, for instance, allowing people to dine in restaurants. This year too, the government announced relaxations both before Eid and Onam. The impact of this is evident in data from Google mobility indices for the state, which show a sharp rise around Onam last year. Of particular interest are the trends in mobility at retail establishments and transit stations, which potentially capture crowding in markets and inbound travel of potentially infected persons to the state. Mobility indices seem to have increased sharply once again before Onam this year, even though the COVID-19 situation is much worse. In fact, Kerala is recording more cases than the rest of the country put together. The rise in mobility coincides with the period of rise in COVID-19 cases in the state, both last year and now. Next slide, please. Why does the Kerala experience matter for the rest of the country? To be sure, Kerala's medical infrastructure has not collapsed due to the pandemic, as was seen in most parts of the country during the second wave of the pandemic. Daily new cases and positivity rates, while they are still high, have come down from their peak levels in Kerala. Why does the current situation in Kerala matter for the rest of the country then? 1. Onam is the first in a series of forthcoming festivals, all crucial for the revival of consumption demand in the economy. Even as inkling of the third wave of the pandemic is bound to crush both consumer and business sentiment and significantly damage the country's economic prospects. Whether or not Kerala's COVID-19 cases surge after the festival will be the first litmus test for whether restoration of pre-pandemic mobility levels trigger the third wave. Despite having a higher number of cases, Kerala has emerged as one of the best performers in terms of vaccination. As of August 19, 2021, it has fully vaccinated 19.3% of the population and administered at least 1 dose to another 33.4%, in addition to offering personal immunity vaccines. Once they have crossed a critical threshold, are also expected to slow down the rate of infection. If cases spike in Kerala, despite a significantly high level of vaccination, then one can expect much worse in other states where vaccination levels are lower. But a mishap-free Onam, at least on the pandemic front, could be really good news for the economy. So there is a warning and there is a good news. We should wait cautiously now for August last week and September first 2 weeks. That will be the litmus test for the country. What happens in Kerala, India will follow. I must thank you all for the patient listening for this COVID-19 epidemiological situation update for today.
Thank you, Dr. Ajit, sir. So, yes, definitely next few weeks, they are a litmus test for every one of us because of the festive season and the situation there in Kerala, which is still not under control. And there are certain raised hands from our panelists. I would like to take Dr. Puneet Chandna first, sir.
Hello. Yeah, good evening, everyone. Thanks for, having another one. My question is, under the theme today to Dr. Jain, with the pediatrics in mind and the third wave, what we are talking about, is going to affect the children in our country more. So, Dr. Jain, allow me to ask you, we've talked about the AEDs and the CPRs by Dr. Vanita Arora today. But with the prompt recognition in mind, we understand that the pediatric cardiac arrest most often results from the progressive tissue hypoxia and acidosis due to respiratory failure. So, can you please explain us, in the sudden arrest from a shockable rhythm, which is, let me say, ventricular fibrillation or pulseless ventricular tachycardia, which is, abbreviated as also PVT. How do we look at the basic life support for cardiac pulseless arrest and for bradycardia under 60 beats per minute for children? What would be
I feel that this is outside the current topic that we are discussing. Though, of course, we could take it offline. Well, we are focused on what we have taken up, the current epidemiological situation, COVID-19.
Right.
So what you have asked is very relevant for the discussion on sudden cardiac arrest.
Right.
But in pediatric age group, the sudden cardiac death is number one, very, very rare, and it's much, much lower. The ratio, if you see, would be around 1:100. That is the proportion versus adults and children, if we consider children as below 12 years.
Right, fair enough. Great. And the vaccination, where you feel vaccination would be important and how fast we might have the vaccines for the children, which is oral doses or maybe nasal drops?
Number one, yesterday Zycov-D was approved for, which is also available for children, if we call children above 12 years to 18 years of age. But this is likely to be very limited supply, number one. Second, there is a commitment that the company has already made for other countries. So the production is limited at the moment. The government of India's official position is they will not start for 12 to 17 age group during this year. They're going to start next year.
Right.
Because the priority is 60 plus age group, number one, and 45 to 59 with comorbidities. So we must maintain our priority. Children in any case have very limited incidence of moderate to severe disease in COVID-19 because the obvious reason is that ACE2 receptors are not there in pediatric age group. So they do not suffer from moderate or severe disease, and deaths are very, very rare. MISC cases are, and actually this has been the experience all through, even during the second wave. Very, very low infection rates and very low admission rates and very low ICU admission rates. So I think the priorities have to continue. We must protect the 60 plus age group and 45 to 59 age group. That priority should not change. Actually, we use these resources for vaccinating children of 12 to 17 years age group. I think we will be defocusing from the resources that we have already. We must focus and ensure that we complete the task that we determined to assign to ourselves sometime in March or January this year, and we must finish the task by December this year and take up new tasks in 2022. And that is what the government of India's official position has been. The production of the vaccine is another limiting factor. Total doses that Zydus Cadila will be able to produce till December this year would be 5 crore, very limited. So that is a constraint, and it has already had commitment to give to other countries except for export. So their actual availability will be much lower. Now you talked about nasal vaccine. Yes, that nasal vaccine may be available by October, November. SII is already they're doing the trials. let us wait till the results come and approval of that process happens sometime in, say, November, December. So then only we can. Nasal vaccine would be good for booster doses. If the government of India decides to go for booster doses, that's very good. And that has been the modus operandi a few countries have adopted. Booster dose of AstraZeneca for nasal vaccine. That is the plan at the moment. Let's see.
Thank you very much for your answer.
Thank you so much.
Vaccine coverage for the priority group is more important rather than extending the vaccination facility to children, which will be covered later on. And now, Dr. Gajen Kumar, sir.
First of all, I compliment Dr. Rajiv Kumar for such a wonderful presentation, very detailed presentation indeed. So I congratulate you, Doctor. And my question is, see, with the Onam, the festive season has set in the country. And in coming 2-3 months, we'll be seeing Janmashtami, then the Dashara and the Deepavali and other so many small festivals in the country. On the contrary, the vaccination program has not picked up as it was required to be because vaccine is not available. Though I understand by now 6 vaccines are approved for use in the country. With this scenario, when you expect the third wave will hit the country? This is my question number 1. And number 2, how far we are prepared to fight out the third wave? These are the 2 questions.
Interesting questions. Astrologers will have their say. My astrological and scientific reading of the current situation, and during the slide presentation you must have seen, what I'm saying is very clearly September, October, November.
Okay.
Very crucial for India. If we are able to tide over these 3 months, we should be feeling we have got over the hump. But we must remember, and I specifically showed you the situation in the US that was deliberate to give you the situation that may happen in India as well. USA today is reeling with the third wave, dramatically disrupting the entire recovery process. The economy of US is now severely affected because of the Delta variant rampaging the south, east as well as northwest of US. And counties after counties are reporting number of deaths, which they thought will not happen. So I feel Indian situation may, if proper action at the micro level, as I always been saying throughout my epidemiological updates, India resides in its districts and small sub-district level tehsils. If district level activity is not done based on the data of the real inputs that they have, and for that they have to work hard to collect the data. For collecting the data, they have to test, and test, trace, treat has to continue. Unless they do it diligently, things may go out of control. Early control is better than actually just watching over the situation when the whole situation is got out of control. So September, October, November, India across the country has to be on its guard. Kerala situation is very, very evident. More than 60% cases are reporting every day what are cases from Kerala. If you look at the deaths, same situation. And last year, if you recollect, India followed what Kerala had already experienced. So this may be possible.
What about my second part, the preparedness for the third wave, especially at district levels?
Exactly. That has been under the government's radar for some time now. Even today, yesterday, Government of India actually released its plan, or the disaster management plan for stockpiling the drugs. The 8 drugs are being stockpiled at the district level. Oxygen, as you know already, the PSA plants and oxygen supply logistics have been ramped up, and infrastructure support systems training as well is being ramped up. So I feel the third wave preparation is better than the second wave preparation.
Quite
So
right.
let's hope third wave doesn't come. But if it comes, India will be better prepared than it was prepared for the second wave.
Right. Thank you. Thank you.
Now, Dr. Kishore Parekh from Vadodara, our Joint Secretary, IUH.
Sir, Rajiv sir, good evening.
Hi, Dr. Kishore, how are you?
Yeah. Sir, it was as usual very excellent session by you. So I do congratulate for the same.
Thank you.
Sir, I would like to know, it has been announced that now about 12 years pediatric group will be vaccinated. So the doses will be same as for adult, and what will be the gap between two doses?
Well, nobody in the government of India has yet announced for the pediatric age group vaccination, number one. Only Zycov-D emergency use approval has been given yesterday. Zycov-D has been tested during the trial process for 12 to 17-year age group, not less than 12 years age group, number one. Second, the Zycov-D vaccine is a 3-dose vaccine and it is not administered through a syringe. It is administered through a pharma jet. So you don't need the infrastructure of needle and syringe. And the doses are same for adults, but the difference is 28 days difference between first, second, and third dose, and completion of the dosage only will give you protection. The 3 doses have to be given. So 3 visits are required, 28 days gap. That is the current trial evidence that was approved, and that is the schedule which has been approved by Government of India. But I must reinforce the information: the Government of India has not yet decided to go for pediatric age group. That is, in India, the definition of pediatric age group has been different in different states and regions. 12 to 18 group, many states consider as pediatric age group, many states do not. The pediatric age group conventionally has been less than 12 years. So there is no vaccine approved for children less than 12 years of age.
Okay, sir. Thank you.
Dr. Tyagaraja, sir.
Good evening, sir, everybody.
Good evening, Dr. Tyagaraja.
Before coming to you, sir, I just want to congratulate Dr. Sandeep Sharma ji of Dr. Arora. It's a very fantastic lecture she has given. And as our Gajendra Kumar sir said, it is a short and sweet. Really, it is a very good. And 2-3 things she has mentioned, that cardio, the coronary artery syndrome and myocarditis and ejection fraction is less than we will have a sudden cardiac arrest in COVID patients, and really true. And I think we need a very broad, at least in our lecture in these COVID patients, because as she said that most of the doctors who are in whichever the specialty they have become the COVID doctors. Yes, it is true, because of our for the sake of our family and our relative, we must know many things about the COVID because it is such a deadly disease. And I think I request to Dr. Sharma ji that please arrange once again this Dr. Arora's lecture, because we have a lot of questions to ask. And now I would like to ask Rajiv Kumar Jain ji, sir. Sir, nowadays, the problem is this COVID has caused a lot of problems with the doctors only. Because see, if you go to the market and see, the people are not afraid of anything. Vaccine government is doing is the best duty by giving vaccination, but people are not following mask, not social distancing. Every festival is full of, especially in Bangalore, we have never seen past some 10 years. So much for this Varmalakshmi Puja, there was so much rush, especially where we stay in Yeshwanthpura and all. The people are so much and so much. It was really every house is celebrating this kind of this Varmalakshmi Puja in a very grand style. And but unfortunately, this may become a a problem for future of this one. And many doctors, I asked, why you are not opening the clinic? He said, see, in a patient, one fever case comes, we will be shivered because we will become very nervous because these COVID patients, the first and foremost is not available the oxygen, beds are this one, and the treatment is very costly, and all these things, it has created a nervous. That's why we are trying to close the clinic. And today, where I am staying in near this electronic city, electronic factory, all of this, most of the doctors, there are nearly 120 doctors are there. They all left to this some hilly side with the family because they this Sunday is the best day for practice. But they do not want to practice. They wanted to go out and enjoy because they are afraid of opening this clinic. This is the most psychological effect. I, Doctor, request Dr. Rajikumar Jain, sir, psychologically, these doctors are nearly vulnerable. And what is your suggestion and guidance that this kind of this one is there? The second thing is, though this third wave is not there in European countries, especially wherever you see now the football game, more than 75% people are attending in Bundesliga, Italian and Premier League. People are allowed to see, and they do not have any fear over this problem. But in India, we do not have such facilities, and people are one side. They are telling the government, we have this one also. Weekend lockdown is there, and after 8 o'clock, the city is not opening. Especially in Bangalore, this is more or less psychological compared to them. And what is your suggestion, sir? How do we overcome the psychological effect, both for doctors and especially for doctors?
Thank you, Dr. Tyagaraja, for highlighting the psychosocial impact of COVID-19 on healthcare workers, especially doctors. This issue has been raised in our forum number of times, and we have also delineated the actions required. We shall also understand that this has a very difficult way to manage actually, because of the very meager resources available for number one, psychiatric services and also counseling services on the ground. But in due course of time, we will have to develop counseling resources and psychiatric support systems availability for healthcare workers, for all healthcare workers, whether they are doctors, nurses, or other healthcare workers. This is not only a problem in India, this is a problem in the entire Europe as well as USA. And all the evidence that is available till date is showing increasing incidence of psychosocial or anxiety, depression, and other issues, and also fatigue, which is what you described. This is not only in Bangalore, this is not only in Karnataka, this is all across the country that healthcare workers are feeling fatigued and feeling the impact of the long continued involvement in managing COVID-19 situation, not only COVID-19 situation management in their workplace, but also managing the COVID-19 situation in their family and in their near and dear ones. So this is definitely a big challenge, and we have to meet it together.
Thank you very much, sir.
So, as Dr. Tyagaraja sir has raised this issue of psychosocial issues which are there with the doctors, especially the healthcare workers across India, that needs to be taken care of, because I think we are the most overoccupied people in the current scenario, and we are the most exposed. So we have to take care of ourselves also during this COVID pandemic, and we have to take care of ourselves, our physical health, and health of our families also. And I would like to have one query, sir. We have been talking of control of pandemic, taking all precautions. Now, what precautions you suggest for the people in their individual residences? Because now with this COVID pandemic still persisting, and still we are afraid of next 2 to 3 weeks when a new surge of cases may occur because of this festivity season. Should people start the normal activities like till now? Many of them, they have not been allowing any visitors at their residences. They are not allowing their maids to come and do their household work. What are the guidance for these household ladies, household people, what they should do, and with what precautions, if they are coming, then with what precautions they have to allow them for these activities here?
Very relevant question, Dr. Sandeep, you've asked. And I would again reinforce, which we have been saying in the past, COVID appropriate behavior with good ventilation in closed spaces, in that order, by all people involved. Prefer outdoor spaces than closed spaces. If you are in closed spaces, spend minimum time in closed spaces without ventilation. Spend more time in closed spaces with good ventilation. And if you are asking about the people who are working in your kitchen or people who are cleaning your household, please ensure that when they are cleaning or working in the kitchen, the exhaust fan is always on and doors and windows are open always. This in itself will ensure that the risk is reduced. Risk mitigation strategies are very clear. The evidence is very clear by now. Vaccination efforts have to be made for not only you and your family. Complete vaccination efforts should be made for the people who are working within your household. And that effort needs to be done actively. It cannot be a passive effort. If all work together, and if all work together all the time, COVID appropriate behavior, enclosed spaces, good ventilation, and spending more time in open spaces, and also continuing to wear mask and ensuring this social distancing will ensure protection to the maximum possible. And even if the infection occurs, it will not cause a severe disease or death. So that itself will be a big relief.
So that is a great idea that we should take all necessary precautions in our households, and vaccination certificates, because now they are well organized certificates which are being issued from the COVID portal after first and second dose. So we should ensure that in addition to our own family members, all these people who are visiting your house or they are coming from for some domestic job, they should be vaccinated, and we should start a community awareness amongst the people who are surrounding us, who are even the shopkeepers where we are visiting for our essential commodities. We should go and tell them also that please get vaccinated, please use mask, because I had been visiting to many shops, and when I see people not wearing masks, we have to tell them that COVID is still there. You should wear mask, not to protect us, but to protect yourself and your family. So in that way, if we continue spreading of this awareness, then it will be a better chance that we all can come out of this pandemic. And this was a great session, sir, and certain unanswered questions were there from Dr. Vanita Arora, because she is a very busy cardiologist, and we could find out some time from her, but we will have some interactive session with her, with question answer session, because she is very good, and she has given a lot of insight on how these sudden cardiac arrest they occur, especially during COVID pandemic, and especially people who are more prone for this sudden cardiac arrest. They should be they should take care of themselves, like people, young persons going to gyms, young persons who are athletes, then people with cardiac comorbidities. They all should be evaluated for with an at least one echocardiography. So, and they should watch their rhythms also, whether it is normal sinus rhythm or some ectopic is there or some tachycardia is there. So in this way, if we are aware of the things, then we can definitely take care. And definitely AED and other things, they will be they are important, but that is also an important topic, and we should have guidelines like other American Heart Association or other guidelines are there. Then we should have Indian guidelines also. That also we will try, sir. Dr. Tyagaraja sir, we will definitely ask her to come and interact with our people, our members, so that all these queries are resolved. And with this, I think Dr. Rajiv Jain sir has given a broad overview of local situation also, especially like we are seeing that America, Europe, again, they are showing rise in number of the cases. So despite they have been vaccinated, and especially the countries like Israel, they are more than 70% vaccinated, but now they are trying, they have issued instructions to the people that they should be careful, that because with the time their antibodies and their immunity might be lowering down, so they might be requiring some booster dose also. So it is an ongoing exercise. We should be careful, and we are very initial stage where we are not, our population is still, lot of it is not properly vaccinated. So still we will have much more opportunities to interact every week. And Dr. Damodar Lele, he has again raised his hand. Dr. Lele sir, would you like to speak, sir? Doc-
Can you hear me?
yeah, sure.
I asked the cardiologist. My
Yeah,
simple question was,
yeah,
if the time
yeah,
for sudden death is just 6 or 7 minutes,
yeah.
how can a person be saved?
So this is what these AED people, those who are manufacturing AEDs, what we have also discussed with them many times, that all facilities wherever they have people, and where the medical facility is not available within 5 minutes, they should have an AED over there. So like if you have a building in which and a hospital nearby, and if that medical facility can't be availed within 5 minutes, then you should have an AED, because that will take care of the sudden cardiac arrest, and you can save the lives. So that is what she has told, that only there is only 5% survival in case of out of hospital cases of sudden cardiac arrest. Dr. Rajiv sir, would you like to elaborate, sir?
Well, the issue is not that simple. Sudden cardiac arrest, in spite of all the advances in medical technology, that decline has been very slow, even in terms of last 25 years or last 50 years. Sudden cardiac death has still not been understood in its entirety. I feel, in spite of in the Western world itself, where AEDs are much more available, as well as the training in using in AEDs is much more common, but the incidence of sudden cardiac death over say 50 years has not reduced dramatically. Leave aside in India, where number one is availability of medical equipment is not there. Even if equipment is available, the usage is not proper or not done by people who even know how to use the defibrillators. Unfortunate, but this only underscores that we need to pursue this subject more vigorously, and especially at our workplaces. All the people should be aware how to use the AEDs and how to do CPR. These two specific aspects at all workplaces are almost essential. And all the public areas, like people engaged in transport sector, all the workers should be aware how to use the AEDs. I have seen during flights as well, people who should be able to practice the correct application of AEDs and CPR. If we score their skill acquisition, there is, I feel, a lot to improve on that front as well. So only skill development will solve the problem. Vigorous attempt at diffusing this skill development. Mere knowledge is not sufficient. That's what I feel.
Yeah, because time is very crucial in case of sudden cardiac arrest, because if we are not doing the resuscitation immediately, then like she told that cerebral perfusion, it decreases over time, and even if you revive the heart, but the damage which occurs to the brain, that can have a long lasting effect, and people he may survive, but he will be comatose. And this we have seen in many cardiac arrests, even in hospitals. Many people, they were resuscitated, but they went into coma, and they remained in this stage for a very long time, and they couldn't recover from this comatose state. So revival of this sudden cardiac arrest patient, it is very important, and it is a skill development. And as rightly said, we should learn, we should all know, instead of watching a sudden cardiac arrest patient, we should start CPR, we should learn CPR, and this we have to preach and propagate everywhere. So with this, I think we can conclude this session, and a lot of new ideas are coming in every session. What what should be the topic for future sessions. So I think with this we can conclude, and we all.
And we should again make a request to subscribe to our Enoch DigiConnect webinar platform on YouTube. And also, if people who have their social media handles, they should share the link of the current video. The today's video should be shared on their in LinkedIn or Facebook or Twitter or Instagram posts. That would be our request to all the members in the audience, whether they are in the panel or in the other sector, and spread the network, spread this message in your WhatsApp groups. So please do ensure that you send the link to the recording on the DigiConnect webinar platform on YouTube in your WhatsApp channels. Thank you so much.
Thank you, sir. Thank you all the participants and all the panelists. We'll see you next week, sir. Thank you.
Thank you.